tear that's not associated with an ACL, which is an isolated sort of tear, I'm going to put in an exogenous fibrin clot. And you need to do this before you tighten your sutures and you tighten your knots. So you identify your tear, you go ahead and you take your sutures, but you don't tighten them, you don't tie the knots, put your fibrin clot and try and put the fibrin clot in between, in the zone where you want the healing to take place. And then once you put your fibrin clot there, then you tie your knots down. And you'll note that once this repair has been achieved, that's the fibrin clot there, sandwiched in between the two ends of the radial tear. This is going to help with the biology. And I typically use this for anything that's a complex radial tear or with chronic tears or with isolated tears when they're not done with ligament reconstruction. And again, you'll note at the 6-month mark that we've got radiological continuity of that lateral meniscus. And this to me is a good sign of healing. One more case, and this is not in the posterior part, this is in the body. So a radial tear in the body associated with a longitudinal tear. So this is a complex radial tear. And when you're repairing these, again, since this is an isolated tear, this is something that I would like to use an exogenous fibrin clot for. So I'm going to first rasp the tear. I'll then take my sutures, then check my trial reduction and make sure that I can get my radial component well apposed. It's not too tight. It's not overlapped. Restore your anatomy. And then once I've confirmed this, I'm going to put my exogenous fibrin clot in there. That's the delivery device for the exogenous fibrin clot. So that comes in. I push it at the area of the tear. You may need to use your probe and then tease it into position. And then once this is done, you tighten your sutures. And when you tighten your sutures, that clot gets fixed into position. And once that clot is fixed and stable, then all you need to do is tie down those knots. And once you tie down those knots, you'll get again anatomical congruity of your meniscus with an exogenous fibrin clot that's going to help with the biology and help with the healing process. That's our end result there. And when we look at the MRI at the 6-month mark, again, you'll note that you've got good radiological healing there of that lateral meniscus with some residual signals there, but a stable meniscus, clinical signs being normal, the patient being fully functional. This is the time that I'd let them get back to sports. Now, many orthopedic surgeons may not necessarily believe that radial tears can actually heal. And so if you ask many orthopedic surgeons, do radial tears of the meniscus really heal? Some will say, look, they don't really heal. Some will say they heal partially, and some will say they heal completely. Well, I think that if it's an acute tear in a young patient that's post-traumatic, then you do have a good chance for complete healing. Take, for example, this complex radial tear in a young patient with an ACL and an MCL tear. So this tear is similar to what we just saw. In this, I'm going to go ahead and repair it, and I've repaired it and got that anatomical congruity. And if you look at the relook arthroscopy 4 months later, you'll note that this tear has completely healed. And it's not just the peripheral zone 0, zone 1, and zone 2 that's healed. You can note that even zone 3 out here has healed. So I think if it's a young patient, it's an acute traumatic tear, then they've got a good chance of complete healing. Even more complex tears like this transected tear. So this is a transected radial tear, a complex tear that's locked in the joint. We've reduced it. And now we'll go ahead with the repair. Now in this repair, I'm going to have to repair the periphery, the peripheral longitudinal part. And I use a fast fix for that. And once I've reduced this, I'm going to go ahead and take my simple sutures for the radial component. So multiple sutures now bringing all of this meniscus into position. And when we look at the relook arthroscopy, which is 4 months down the line, you'll note that this tear is what it looks like now. So this is 4 months down the line, complete healing of that radial tear. Those are the sutures that have synovialized out there. You can see that these knots, although these are 2-0 non-absorbable sutures, you'll still note them, but the knots are significantly synovialized, so they don't cause any impingement. And you've got good restoration of that meniscus. And again, not just zone 0 and zone 1, but zone 2 and zone 3 too. And this encourages me then to repair many more radial tears. What are the success rates for radial tears? Well, a lot of studies have shown success rates upwards of 70%, and in some studies reaching also 100%. So I would encourage you to repair these tears. You do need to protect your repairs for a significant amount of time. So I normally advise 6 weeks of non-weight bearing. I do allow range within a few days, but I will keep them non-weight bearing for 6 weeks and then slowly progress them with load bearing, and certainly don't allow high impact activities or hyperflexion for the first 4 to 6 months. Thank you.
Thank you, Dinshaw. Great cases.
Thank you very much for your great lecture, Partiwala. While we're loading next conference of RAM Tears of Sangui, perhaps are you connected? I think, Dr. Partiwala, I can ask you about how do you, having the follow-up, you have an MRI for all the patients you treat with a radial tear that you repair. It's only a clinical exam, and you there show an arthroscopy, like a second look. Do you use often that second look arthroscopy in your radial tears repairs?
Not routinely. So, can you hear me?
Yes, I hear you. Thank you.
Great, great. Okay, so not routinely. So normally, if I've got a patient, I'm going to certainly see him with all of the clinical parameters. And if all of the clinical parameters are okay, then I will routinely get an MRI done at the 6-month mark. And that MRI is to just confirm to me that, look, the healing is good. He's got clinical restoration of the meniscus. His radiological healing is good. And that then allows me to allow him high impact and getting back to sports. In some patients, when we do it as a 2-stage procedure, so sometimes when you've got a multiple ligament injured knee, you've got a locked meniscus, at times we've done this as a staged procedure. So if we do it as a staged procedure, then I do get the opportunity to do a second look for that meniscus. That's quite rare, but this gives us a good opportunity to see how that meniscus heals. So often when you go in for your second or your third ligament at the 3-month or the 4-month mark, then I think that's a good sign of seeing what that meniscus healing looks like. Not routinely would I do a second look. This would only be for some indicated cases.
Thank you very much, Dr. Partiwala, for your comments and for being connected at this time. Now
Thank you.
Now we can load the RAM Tears conference of Sangui. No sé si el auditorio tiene alguna pregunta, la trasladamos.
Good afternoon. Today my topic is repletion. I'm Zhang Hui from Beijing Jishuitang Hospital. This is my disclosure. I have no interested relation to this presentation. Repletion is a special type of meniscal lesion involves the peripheral attachment of the posterior horn of the medial meniscus, commonly combined with ACL injury. If we perform the arthroscopy examination from the anterior lateral portal, it is very hard to find repletion. The ordinary examination technique was hard to identify the repletion. So the repletion is called hidden lesion. We need to put the scope into the transcondylar view and to find the repletion. For more clear view, we can use the postmedial portal to identify the repletion. From the postmedial portal, we can find the repletion and know the lung's location and relationship between the capsule and the meniscus. These two pictures in the bottom show the normal rump area. This is the right knee with the transcondylar view using spinal needle to probe the conjunction of the posterior capsule to find there is no tear or not. And the other picture is the postmedial portal to show the rump area is complete. For the incidence of rump lesion, in the literature, the incidence of rump lesion is around 9%, but in our study, the incidence of rump lesion is a little higher. It's about 16%, because for every ACL rupture, we will perform the arthroscopic examination for the rump area to find there's rump lesion or not. How to diagnose? The MRI was recommended as a routine method. It can be helpful in detection of the rump lesion. But we should know, for MRI examination, the sensitivity was low to moderate in the literature, and sometimes some patients will be misdiagnosed. So how to diagnose? We think most important thing is to standardize the arthroscopy exploration. We need to use a transcondylar view to find the rump. For every patient with ACL rupture, we recommend to examine the rump area to find there is a rump lesion or not. If there is a rump lesion, we need to use a postmedial portal. The rump lesion will be more clear viewed from the postmedial portal. We can know the length, the location, and the relationship between the meniscus and the capsule. The arthroscopy assessment need to be performed step by step. This is an example. A male patient, 19 years old, left knee injured, ACL rupture, and rump lesion and lateral meniscus root tear. The KT1000 was 7 mm. The pivot shift was 2+. First, we use a transcondylar portal. We push the scope into the postmedial compartment, and we can find the rump lesion in the conjunction of the postmedial capsule and the posterior horn of the medial meniscus. Then, we can use a spinal needle to probe the conjunction of the capsule and the postmedial portal to identify the rump lesion. That will be more clear. These two pictures show the comparison between the transcondylar view and the postmedial view. From the postmedial portal, we can see the rump lesion more clear. We can know the length, the location, and the rump lesion. Then we can perform the repair from the same portal. For the repair technique, we can use different repair technique for the rump lesion. We can use all inside suture technique or inside out suture technique. Both is okay. My first choice is all inside technique with suture hook. We can put 2 cannulas in the postmedial portal. The lower, we put the suture hook inside into the joint, and to perform the repair, we use number 0 PDS2 suture to repair. We can put several stitches to suture the rump lesion. And this is the final result after the repair, as the video shows. And for this patient, 1 year later, we performed the second look arthroscopy and find the rump lesion was completely healed. My second choice is the inside-out technique. For example, this patient is a bucket handle tear of the medial meniscus, and the tear extends to the rump area. So, in the rump area, there is a double tear of the medial meniscus. In this case, we use the inside-out technique to repair, stitch by stitch, until we reach the posterior horn. Finally, we found the rump area was covered about 5 to 6 stitches. For this case, we think the inside-out technique can be used for the repletion repair. And also, 2 years later, we perform a second look arthroscopy. We find the posterior horn of the meniscus was completely healed. The all inside technique or inside out technique, both is okay for repair the repletion. And how about the healing rate? From the literature, we know the healing rate is super high. It's around 97%. So there's a question comes out, whether the repletion must be repaired or could be mastered neglected. For example, if there's an unstable repletion, that means the length of the repletion was more than 2 centimeters. This kind of repletion will have hypermobility and downward displacement peripheral part of the torn meniscus. That would make it difficult to heal spontaneously without surgical repair. I think this kind of repletion, unstable repletion, need to be repaired. But for the stable repletion, for example, like this patient, from the MRI, we can find high signal in the posterior horn of the medial meniscus. And during the operation, we find the repletion length is around 1 centimeter, is stable, and we just leave it alone. 1 year later, from the MRI, we can find the posterior horn of medial meniscus is completely healed. Also, in the second look arthroscopy, the repletion is completely healed without repair. But there is no control study to support this hypothesis. So, to answer this question, we designed this study. It is a randomized control study. The inclusion criteria is complete ACL injury and concomitant with stable repletion. 40 patients was performed repair and 33 were performed debridement. Finally, the clinical results show stable repletion of the medial meniscus treated with debridement alone during the ACL reconstruction will result in similar clinical outcomes compared with those treated with surgical repair. So for the conclusion of this topic, the repletion is so-called hidden tear of the medial meniscus. The diagnosis is important. We can use MRI. That was helpful in detection of repletion, but we should know there's low to moderate sensitivity, and some patients will be misdiagnosed. So, recommend during the operation, the standardized arthroscopy explosion of the postmedial compartment is needed in every ACL injured knee, especially in those chronic ACL deficient knee. We can use transcondylar view or postmedial view, use a spinal needle to probe the meniscal capsule junction to find there is a repletion or not. For the repair technique, if the repletion is unstable, that means 2 centimeters longer, and the downward displacement, this kind of repletion need to be repaired. We can use all inside technique or inside out technique, and the healing rate is relatively high. It's more than 90%. And for the stable repletion, we can just perform a debridement during the ACL reconstruction. That will result in similar clinical outcomes. That's all. Thank you for listening.
Thank you very much, Dr. Hui. Sorry if I pronounce incorrect. Please, we can start loading the next conference about root tears from Dr. Bancha Chenchuhi. I don't know if Dr. Hui is connected in the Zoom meeting.
Good afternoon. I'm Dr. Bancha Chunchujit from Thammasat University, Thailand. It's a great privilege to be part of this meniscus symposium. This video shows the anatomy of the medial and lateral meniscus. The lateral is more mobile comparing to the medial side. The meniscus root function is to convert axial tibiofemoral load to hoop stresses, and the 50 to 70% of the knee joint load was absorbed by meniscus. Biomechanical study by Robert 2008 found that tear of the posterior root of medial meniscus is comparable to total meniscectomy. How about the natural history? Once the root is torn, the meniscus will detach from the tibial plateau. This will alter the knee kinematics. Then, meniscus will extrude more and more, finally diminishing the hoop stress effect, resulting in rapid progression of osteoarthritis of the knee. Many articles mention about the natural history of the meniscus root tear. One article found that one-third of the patients need joint replacement 3 years after the initial diagnosis. JBJS 2009 mentioned about the high correlation of osteonecrosis and root tear. They conclude that 80% of osteonecrosis associated with medial meniscus root tear. In this literature conclude that the incidence of medial meniscus root is very high, nearly 80% in primary total knee replacement. These are the differences between the medial and lateral meniscus root tear. The medial meniscus root tear is common in middle age, can be acute or chronic repetitive injury, can be from minor injury like twisting, squatting. The tear configurations is always radial, close to the root attachment. For the lateral meniscus root is found in younger age, acute traumatic injury, and always combined with ACL injury. This cadaveric study from arthroscopy 2021, after performing the lateral meniscus root detachment, it significantly increased the rotational and translational laxity at 30 degrees of knee flexion. These are the risk factors for posterior meniscus root tear: varus malalignment, increased BMI, female with high KL grading. Clinical presentation. The patient always complain posterior knee pain, especially when walking or deep bending. Examinations reveal joint line tenderness, McMurray test positive, and severe pivot chip test positive in lateral meniscus root tear. MRI characteristics of meniscus root tear includes meniscus extrusion from edge of tibial plateau, goat side positive in sagittal view, cleft side positive in coronal view, and bone marrow edema of the tibial plateau. Lateral meniscus root is often misdiagnosed, 33% missed on MRI. The normal lateral meniscus root should be like Y shape. One limb is root, one limb is Risberg ligament, like the first picture. Sometimes we see no gap of the meniscus. It's just floating like the third picture because the Risberg ligament is still attached. Dr. Raplat classified the meniscus root tear into 5 types. The most common is type 2, repair versus meniscectomy. The recent meta-analysis comparing long-term X-ray outcome and conversion rate to joint replacement. Conclusion is that the root repair group had lower rate of OA progression and conversion to joint replacement. We need to consider 3 factors: alignment, cartilage, and ligament. The treatment options include conservative treatment and operative treatment as shown. The goal of root repair is to prevent the arthritic change. It's indicated for acute or chronic tear without osteoarthritis. KL should be less than 2. The good candidates for meniscus root repair are acute injury, no joint space narrowing, and extrusion less than 3 millimeters. Don't do root repair if there's subchondral bone collapse, malalignment more than 5 degrees, and BMI more than 30. These are the bad candidates for root repair: chronic injury, joint space narrowing, large tear size, and extrusion more than 3 millimeters. What is the proper timing of meniscus repair? This article in American Journal of Sport Medicine last year suggests that early surgical repair of meniscus root within 13 days after the injury can prevent the progression of medial meniscus extrusion. Now let's talk about the surgery. I will discuss about the different techniques of surgery, suture constructs, and do we need extrusion reduction. I prefer this position. I break the table, hang the leg down, and I can move around the knee. Let's talk about the first technique, the transtibial pull-out repair. This is our technique published in 2016, medial meniscus pull-out repair with the use of tibial tunnel suturing technique. We repair the root in Mason-Allen configuration and secure with cortical button. In 2016, George proposed the double tunnel pull-out technique. He claimed that this technique may increase the contact surface at the root and better contact healing. This is my patient with double tunnel pull-out technique. I did the suture bridge configuration like rotator cuff repair to increase the surface contact healing. In systematic review, complete healing on MRI vary from 60 to 90%. Extrusion was reduced only half. Most patients improve functional outcome after the surgery. 80% has no progression of osteoarthritis in short-term follow-up. Professor Somsak from Chulalongkorn and the team proposed the very smart soft anchor fixation using flexible drill bit, which can press the soft anchor more vertical. This is my preferred technique of meniscus root repair with soft anchor. The benefit of this technique is that no need to do the posteromedial portal, no tunnel convergence, and no bungee effect. The medial joint space always really tight during the surgery. This is a big problem during the surgery. I propose the technique to open the medial compartment we call magic point release. The landmark is 1.2 centimeter above the joint line, connecting to adductor tubercle. Transtibial pull-out versus anchor suture. Dr. Kim compared two techniques, pull-out repair and suture anchor repair, and found that there's higher rate of incomplete healing in the pull-out group. Professor Imhoff and the team from Munich compared suture anchor and pull-out repair. They found that suture anchor technique provides superior biomechanical properties. How about the suture construct? Biomechanical testing proved that the double locking loop is the strongest. Another interesting stitch is the simple cinch stitch. Single pass, high load to failure, low cyclic displacement, and decreased cut-through. This article proposed that the non-reduced meniscus extrusion, decreased shock absorption, and increased progression to osteoarthritis. So, only root repair may not enough. Dr. Jin Gu Kim found that the decreased meniscus extrusion group have better leach home and IKDC score and less KL arthritic progression. I propose the surgical technique for arthroscopic direct meniscus extrusion reduction. I use a mid-medial portal to place a soft anchor at the edge of the tibia, then reduce the meniscus to the anchor in horizontal mattress fashion. When should we do HTO in root tear? I prefer one leg standing view because many times two leg standing view look very normal. This technique is very useful to detect the actual joint space narrowing and axis deviation. The indication for HTO plus root repair includes acute onset of root tear less than 6 months, medial extrusion less than 5 millimeters, and the KL less than 2. 50 years old lady just progressive right knee pain for 6 months after squatting. MRI show the meniscus extrusion with subchondral marrow edema, the Krebs side positive and the goat side positive. First, I did arthroscopic meniscus root repair with Mason-Allen fashions, followed by HTO. How to save my suture repair from HTO saw blade and chisel. I use the endobutton drill bit to protect my suture all the time during the HTO. 6 weeks after the surgery, the patient doing very well. Dr. Kim proposed that it's not necessary to repair the meniscus root during HTO because the outcome is the same. Another study also supports this. Root repair may not need during HTO. This is the last issue, meniscus root reconstruction. It was proposed by Dr. Jin-Gu Kim in 2017. The benefit of using gastric instead of suture is that it's a soft tissue bridge from meniscus into the metaphysis bone, so it can close the bigger meniscus defect with good healing potential. 60 years old, medial meniscus root tear. I did the root reconstruction for him. Nice root reconstruction healing into the bone 2 years after the surgery. Rehabilitation for the root tear need to be very slow. It's easily torn if putting the weight on too early. 6 weeks, no weight bearing. 6 to 12 weeks, progressive weight bearing. No squatting, no jumping for 9 months. Take home message. Root repair is indicated in all acute tears. In chronic tears, we assess the severity of arthritic change. In mild and moderate arthritis, we do repair or recon depending on the extent of extrusion and gap, with or without HTO. In severe arthritis, we recommend HTO or joint replacement. Thank you for your attention.
Thank you very much, Dr. Bancha. It was a great lecture. Now, please, we can load next conference of Dr. Koga, degenerative meniscus tears, and at the end we have all the questions and answers. Please.
Hello everyone, I am Hideki Koga from Tokyo Medical and Dental University, Japan. First, I'd like to thank you for inviting me. My topic today is how I treat a degenerative meniscal tears. This is my disclosures. Cause of knee OA can be divided into two, primary and secondary, and the most frequent cause of secondary OA is trauma such as ACL and meniscus injuries. However, recent evidence has demonstrated that even the primary one can be mostly meniscus related. If you look at characteristics of meniscus injuries in elderly people, they are based on degenerative changes, malalignment affects its treatment, and meniscus injuries initiate OA. Meniscus injuries and extrusion cause increased biomechanical stress, leading to synovitis and bone marrow lesions, and with malalignment, ending up with OA. Therefore, diagnosis and treatment of meniscus injuries are important for management of early OA. ESCA consensus for degenerative meniscus injuries has been published recently that indicates that if patients don't have mechanical symptoms, conservative treatment is recommended, and meniscectomy should be performed for only ineffective cases after more than 3 months of conservative treatment. But there are several types of injuries that need surgeries at early phase, such as flap tear flipped to tibial side, unstable horizontal tear, and most representatively, posterior root tear with extrusion. In such cases, meniscectomy should be as minimal as possible, and repair should be tried as much as possible. But worse outcomes would be expected by repair, as tears are based on degeneration. While meniscectomy exacerbates OA, we have to struggle with this dilemma. So my surgical strategies for degenerative meniscus injuries are performing meniscus repair with as secure fixation as possible. Repair is augmented by centralization technique for meniscus extrusion. Biological augmentation is necessary, especially for isolated meniscus repair, and combining around knee osteotomy for malalignment. So how to improve outcomes after degenerative meniscus repair? First of all, secure fixation is required. For radial tear, I prefer inside-out repair with so-called tie grip suture. 2 vertical sutures are applied at both sides of the tear first, then horizontal sutures are applied over the vertical sutures to avoid cheese cut, achieving secure fixation. For posterior root tear, full-out repair is applied by combination of racking hitch knot and modified Mason allen. For horizontal cleavage tear, I prefer to do vertical sutures to close the cleft. Then repair should be augmented by centralization technique. Again, meniscus extrusion is correlated with progression of OA. We have developed a new technique called centralization for extruded lateral meniscus. The idea is to centralize extruded meniscus by anchoring meniscotibial capsule, and we reported excellent 2-year outcomes. So we decided to apply this technique to medial meniscus extrusion. Then osteophytes should be resected if it exists. as medial meniscus extrusion is highly correlated with size of osteophyte in early OA. Biological augmentation is also necessary. Biological augmentation is very important, especially in isolated meniscus repair. To promote healing, I routinely perform rasping and bone marrow stimulation. You can also apply fibrin clot, PRP, or stem cells if available. In addition, we combine osteotomy aimed at neutral alignment in cases with varus alignment. Worse outcomes are expected in cases with varus alignment. Our concept for osteotomy is osteotomy aims at neutral alignment, specifically percent mechanical axis of 57%. Then we combine meniscus repair and centralization augmentation to restore meniscal function to expect improvement in functional outcomes and sports performance, and possibly long-term outcomes. This is a case of MMPRT right knee. The posterior tear as well as meniscus extrusion is confirmed. Fibrous tissues around the torn meniscus edge is removed. The pleural tunnel is aimed medial and posterior to the anatomic insertion site, so the torn edge of the posterior root can be inserted into the tunnel. A guide wire is inserted using the guide for MMPRT. Then the 6 mm diameter tunnel is created. Cartilage around the tunnel is removed using the curette. These procedures allow the meniscus bone healing. A knee scorpion with 205 wire is inserted, creating mattress suture at the torn edge. The suture post is placed in front, and tied suture is left uncut, so this suture can be put into the tunnel as well as work as a locking suture against suture tapes applied later. Loop end of the suture tape is passed medial to the mattress suture using the scorpion. Then racking hitch knot is applied to the suture tape, making sure the knot is secured perpendicular to the mattress suture. Another suture tape is applied using the same technique, and all the sutures are put into the tunnel. However, the torn edge cannot be inserted into the pleural tunnel, and reduction of the medial meniscus extrusion at the posterior medial part is not achieved. So a mid-medial border is made just anterior to the medial femoral condyle, and the meniscotibial capsule under the medial meniscus is released from the medial tibial plateau from anterior to posterior using an arthroscopic grasp to the mid-medial border for mobilization of the medial meniscus. A low posterior medial border is made using a spinal needle just below the medial meniscus and 5 mm posterior to the posterior border of superficial MCL. A knotless fiber tack soft anchor is inserted at the edge of the medial tibial plateau. A repair suture and shattering suture loop are retrieved from anteromedial border. A scorpion is inserted and the straight end of the fiber link is passed through the capsule at the margin between the meniscus and the capsule for suture relay, and the repair suture and the shattering suture loop are passed from inferior to superior. The second anchor is inserted 1 cm anterior to the first anchor. All 3 sutures are retrieved from the anteromedial border. A microsutureless small curve is inserted and penetrates the capsule from superior to inferior at the margin between the meniscus and the capsule. Suture relay is used to pass all the sutures from the second anchor. The shattering suture loop from the first anchor and the repair suture from the second anchor are retrieved from the anteromedial border. The repair suture from the second anchor is passed through the first anchor. without tensioning it. The third anchor is inserted, and the same procedure as the second anchor is repeated, and the repair suture from the third anchor is passed through the second anchor, and then the repair suture from the third anchor is tightened. The repair suture of the second anchor is also tightened, completing centralization. The extruded medial meniscus is reduced, and reduction of the repaired posterior root to the pull-out tunnel is achieved after final fixation. This is a representative case, MMPRT with various alignment. I performed OWHTO aimed at percent MA of 57%. Arthroscopy confirmed MMPRT and extrusion, so MMPRT repair was augmented by centralization. This is second look finding at time of plate removal. As you can see, posterior root is completely healed with very good tension, and reduction of extrusion is preserved. To summarize, in order to treat degenerative meniscal tears, as meniscus is degenerated, secure fixation as well as biological augmentation is necessary. In order to take care of meniscus extrusion, augmentation by centralization should be considered. And most importantly, malalignment should be taken care of by appropriate osteotomy. Thank you very much for your attention.
Thank you very much, Dr. Koga, for your great lecture. Now we're going to load presentation of Dr. Shin-Gu Kim, meniscus transplantation, please.
Hello, my name is Jin-Gu Kim, Myeongji Hospital, Hanyang University, Korea. My topic today is Korean experience of meniscus allograft transplantation. I have no conflicts of interest to declare. Meniscus transplantation is potential biologic solution for the symptomatic meniscus deficient patients. This will alleviate pain, improve the knee function. However, there is no evidences of restoring the normal anatomy and the function of the knee joint. Korean government covered the insurance, the age from 20 to 45 years, and no cartilage damage, and with good joint alignment, and 1 year for the medial, 6 months for the lateral, after total or subtotal meniscectomy. We usually use a fresh frozen allograft with stored with minus 80 degrees of Celsius. This is a simple and minimally immunology. We don't use any gamma irradiation and EO sterilization. For the size matching, we usually use a simple X-ray bipolar method to adjust the magnification effect for the 70% for the lateral, 80% for the medial. We sometimes use the contralateral knee MRI to measure the meniscal height. I prefer reducing the size by 5% to reduce the meniscal extrusion. For the surgical technique, there is 2 different methods for soft tissue fixation and bony fixation. According to the biomechanical study, bony fixation showed superior biomechanical properties with the joint contact space and the joint contact pressure. And the lateral meniscus with the bone bridge technique, however, medial meniscus, we usually use bone plug method for it is too far, and between two ends there is ACL insertion. For the technical tip, if it is too medial, there is a tight graft. For the lateral, there is a loose subluxated graft. So the bony position is very important. Spur excision is recommended to decrease the allograft extrusion. For the rehabilitation, for the standard rehabilitation allowed range of motion with maintaining 6 weeks of the partial weight bearing. However, this showed considerable extrusion after transplantation. So we tried to delay the rehabilitation and compared with the standard rehabilitation method. So we applied the delayed rehabilitation for 3 weeks of long neck cast, followed by 9 weeks of unloading brace. The conclusion will be the delayed rehabilitation showed less coronal graft extrusion, reduced the progression of arthrosis, showed no difference in clinical outcomes. There is a meta-analysis of 9 studies for the mid-term around 80 to 90%, long-term around 50 to 60% of survival rate. This is a very promising report from Korea. 15 years survival rate was 93.3% with the bony fixation technique. I have performed more than 600 transplantation until now with a good, fantastic international collaborating team. This is our result for mid-term, for there is no difference between medial and lateral meniscus transplantation. And until mid-term follow-up, the continuous improvement of knee function, considerable knee meniscal extrusion was observed. However, this extrusion progression showed a significant correlation with arthrosis. We just finished it to submit our data to midterm outcome with the good joint space with moderate joint space narrowing. There is no difference. And there is a significant difference of joint space widths. And this is the case for considerable extrusion with the joint space narrowing. So this suggests that the bad results and the graft extrusion showed in the already narrowed joint space. So proper joint space narrowing management at the time of transplantation is required. This is our future direction discussed with the International Meniscus Reconstruction Forum. This is a challenging case for 41 years of male who was a national soccer team player, still working as a soccer director, showed normal alignment with advanced osteoarthritis, no meniscus, severe pain. He wants to maintain his sports activities now. There are several options for varization osteotomy, transplantation, cartilage repair, arthroplasty. Even single procedure is not the option for these patients. So we decided to combine all 3 procedures, distraction arthroplasty with the allograft transplantation and the cartilage repair. There is a wonderful report from Hiroshima, Japan, by Professor Adachi and Ochi. They reported very nice clinical result after distraction arthroplasty with their fixator. So we use the leader of external fixator with the distraction. This is our clinical surgical technique. The 3 months after the combined procedure, there is a well-positioned graft and the cartilage healing evidence. After clinical follow-up 7 months, they were maintained the joint space and with the flexion up to 120 degrees, clinical score around 80. We reported the return to sports and work after distraction arthroplasty procedures. So we evaluated 21 patients with the best occupation intensity during 5 years before surgery with the heavy and moderate level. There is a continuous improving clinical scores, function test, and radiologic images from 6 months to 2 years of follow-up. There is a technical activity level reached up to 6 point, and the considerable joint space width is improving until rest follow-up. This is the case from preoperative 6 months after the surgery and the rest follow-up. So disrectional arthroplasty plus the lateral transplantation combined with cartilage repair showed high rates of return to sports and return to walk and rest follow-up. There were significant improvement in clinical outcomes and in the radiologic joint space widths. One-stage joint salvage treatment showed a promising option for young and active patients with advanced osteoarthritis. This is our conclusion. Meniscus transplantation has been proved as an effective treatment for the patients with meniscus deficient, and the coverage will be broadened. For advanced cartilage region, transplantation was a viable option to improve clinical outcomes, even though relatively low graft survivorship. Delayed rehabilitation has effects of reducing graft extrusion and the progression of osteoarthritis. Thank you very much for your attention.
Thank you very much, Dr. Kim. Great lecture. Now, please, we are going to load next presentation about discoid meniscus from Dr. Patrick Yang. At the end, we can have the questions and answers.
Brochure. So what's the discoid meniscus? I think we understand that it is quite common mainly over the lateral side of the knee joint, and there's no definite sex preference. And not uncommonly, it has been seen as a bilateral discoid. So about 2 to 16% of the symptomatic discoid are indeed bilateral. And it is supposed to be associated with different problems, including generalized ligamental laxity. Well, in classification of the discoid, there are quite a number of classification systems, but the most popular is still the Watanabe from Japan, right? So essentially, it's just quite simple classifications divided into incomplete and complete discoid, and the last but not the least is the wrist ligament type. Well, I just want to spend a little bit of time on talking about the wrist ligament type of discoids, because probably this is one of the most difficult to manage, to be managed, right? So in different from the complete and incomplete discoids, the wrist ligament type, as it named it, there is a ligament linking the posterior half of the discoid meniscus to the femur, right? We call it the wrist ligament, right? Which indeed is not always present in the lateral discoids, but once it is present and associated with discoid meniscus, it can cause a very unstable discoid meniscus, and that can always cause trouble, right? Well, this is a case of a 6-year-old kid, right, with a clicking. You can see that upon flexion and extensions, right, and that creates quite a bit of discomfort. There's no definite, very genuine knocking, but the kid is worried about that, and not to talk about the fathers and the mothers are worrying that, oh, this is something which can hurt. There's MRI features of the discoid meniscus. For some of the discoid meniscus, it's just like a full disc, or some is like a half disc. But for some of the discoid meniscus, it can be associated with tear, like for example in the left-hand side of this MRI, which is a horizontal cleavage of the thick discoid leg. There's another pictures of a discoid meniscus, which sometimes can be very, very big, and it's like a chunk of chocolate inside the knee joint, and you can imagine that it can cause a lot of discomfort and mechanical problems and over the knee joint. How about the treatment, right? Well, I think my algorithm is, first of all, is it symptomatic or asymptomatic, right? Most of the asymptomatic discoid, I don't think we need any treatment except for some exceptional case, which I will mention in the later part of my presentations. And the other second important parameter is whether the discoid is intact or is torn, right? Definitely a torn discoid meniscus can be more troublesome, but doesn't mean that an intact discoid can always be forgiven. It still depends on whether it is symptomatic or not, right? And of course, the type of discoid, as I mentioned earlier, is also very important. Well, essentially, the complete and incomplete discoids, if it is asymptomatic, most of the case, not all, that we can manage it non-operatively. However, for a lot of respiratory ligament, it can always cause problems and trouble. So most of these cases, we may need operation. There is a paper published by Professor Ang from Korea, which we all know him very well, very well respected Korean surgeons in knee surgery. So he mentioned that operative treatments with complete or major partial meniscectomies always yield a very poor results, resulted in severe degeneration of the knee joint. So he does not advocate, complete meniscectomy for all this discoid meniscus, even though if it is symptomatic. However, he recommends what we call reshaping. At that time, we got reshaping, and later on we call it saucerization of the discoid meniscus into a normal C-shaped meniscus. In his papers, he found with a minimum follow-up of 8 years of 48 knees, the outcome is quite satisfactory for those with saucerization, reshaping of the discoid meniscus when compared with almost like a subtotal meniscectomy. So with this, all this experience from the previous experts, I draw my treatment algorithm and protocol as follows for painful or torn discoid meniscus. Well, if this is a complete or incomplete type, I will saucerize the discoids back to the semilunar sheath-shaped meniscus, plus or minus if needed for repairing the torn or unstable posterior part of the meniscus. However, if it is a respiratory ligament type and cause pain or tear, we, apart from need a saucerization, we need a quite extensive, good repairing of the unstable posterior horn, which indeed very often cause a lot of mechanical symptoms, including locking and pain. Well, saucerization, as it's named, is very easy. Essentially, you cut it and make it into a C-ring, as shown is here. But having said that, there are some skills and tips in the proper way to do this saucerization, especially if it is associated with the need of suturing or repairing. So this is another picture showing how I saucerize, this complete discoid meniscus back to a C-shaped meniscus. So this is a complete meniscus, discoid meniscus. First of all, I saucerize it, and then you can see there's a different peripheral tear, which we repaired that. In this case, on the body with outside-in technique. This was some of my previous experience in which published in the Hong Kong journals of orthopedics, right? And indeed, in that series about 6 years back, right? So there were 28 discoid meniscus, all below the age of 15 years old at the time of surgery, and altogether, with a mean age at operation 11 years old. Majority of them complete versus incomplete, and versus respiratory ligament type is a 16 versus 7 and versus 5, right? And 7 of them you just did saucerization, and then majority of them were repaired after saucerization, and only 1 cases we need subtotal meniscectomy. Just give you an example. This is a 6 years old boy, okay, with left knee sprain injury with pain, and then in extension neck with knocking. And he was seen by bone setters, which is kind of like Chinese traditional medicine doctors, and treated with some sort of manipulation and manual therapy. But he got persistent pain and swelling with limited range of motion, and most importantly, cannot extend the knee. And on examination, there was tenderness at the lateral joint line. Here's the meniscus MRI. You can show that it's a big, thick discoid meniscus with partly torn and flipped, into the notch of the knee joint. So as from the coronal view, the same findings. So how to manage, right? With this MRI shows a torn lateral discoid meniscus extending extensively from the posterior horn to the body and then to the anterior horn. and there was a complex tear in this pattern, which include longitudinal, radial, and laminated tear with the fragment flipped and causing locking of the knee and preventing full extension of the knee. So what have been done is that I have performed sulfurization to a C-shaped meniscus and then repairing the whole meniscus. Anterior horn, we use outside in technique, body anterior part outside in technique, body at the posterior part, and the whole posterior horn, I use a posterior portal direct repair with all inside technique. So this is how I perform the operation. First of all, I repair the anterior horn and the body first before I do a sulfurization, which I will think that is easier for me as well. We will not overdo it and incidentally cut part of the meniscus and truncate it. So that's why I usually freshen it up the torn edge and then start to repair the anterior horn and the body so that the whole meniscus can be, reduced back first, right? Even though it's still big and large. And then with that, I can perform a beautiful, easier sulfurization so as to, prevent overdoing or underdoing of this cutting of the sulfurization, right? So this is how I did and performed the procedure. So, okay. And then after that, you can deal with the posterior horn of the right. So I set up a posterior portal. You can see that this is the back of the discoid meniscus, thick and unstable. So I use suture hook, right? And then, to pass it around the capsule and the meniscus, and then repair that, right? And then we do that one by one. So that, like for this cases, I pass altogether three sutures, right? And to repair the posterior horn of the torn discoid meniscus, right? After repairing the anterior horn body and doing the sulfurization. My rehabilitation regime is as follow: knee brace with control range of motion, full extension 2 weeks, and then for 2 weeks 45 degree, 2 weeks 90 degree with non-repair. So my treatment algorithm is that for painful discoid meniscus is sulfurization and retaining the meniscus if possible, repairing the unstable portion. The only problem is that, well, for some of the lateral discoid meniscus, there's clicking but no pain. Should we fix it or wait? Well, for clicking meniscus without pain, right? Well, there are some studies showing that it is highly associated with tear in those complete discoid lateral meniscus, right? So that means that even though it does not cause pain, it can end up in symptomatic treatment, symptomatic pain, as well as later on degenerations. So people advocated that if it's unstable meniscus, if a discoid lateral meniscus, then you operatively, especially if it's a complete type, right, which is more prone to tear when compared with the incomplete type, right? Why for clicking discoid meniscus? Unless it's an incomplete type. If it's a complete type, which has been shown to have poor clinical outcome, I usually, will try to fix it and repair and sulfurize it, very much like a wristband. So this is how, just showing you examples, similarly reducing that and then fix it, and then, repairing that, and then for this relatively just clicking without pain discoid meniscus. Right? So before the operations and 3 years after the operations, which shows a beautiful. So finally, I just want to reiterate my surgical indications, right? For complete discoid lateral meniscus of the child, if it's asymptomatic close observation, if it's pain with or without click, we need surgery. If it's a click without pain, also need surgery. If it's an incomplete discoid lateral meniscus, asymptomatic close observation, symptomatic, we need surgery. Okay? If it is click without pain, because of previous indication, evidence shows that it is a more forgivable type, we will closely observe. Right? So the answer for this patient, 10 years old, lateral discoid meniscus, clicking without pain, but if this is a discoid complete lateral meniscus, I will still fix it. Right? So there's last but not the least, I want to thank my research team, my colleagues for supporting me over the years. And once again, thank you for the invitation. Thank you.
Thank you very much, Dr. Jung. Now, please, we can load next presentation. with Nobu Adachi, biological enhancement of meniscus repair and meniscal regeneration. Then we have the question. Thank you.
My name is Nobuo Adachi, professor and chairman of Department of Orthopedic Surgery, Hiroshima University, Japan. Today, I'm going to present biological enhancement of meniscal repair and regeneration. Meniscus has very important functions such as shock absorption, load distribution and transmission, joint stability, congruency, lubrication, and nutrition. Meniscus also contribute to the proprioceptive function. As you know, the meniscal injury is one of the important risk factors for knee osteoarthritis. Even partial meniscectomy causes alteration of distribution of the knee joint. This brings damage of articular cartilage, leading to osteoarthritis. This is the radiograph of 45-year-old male who underwent partial meniscectomy of lateral meniscus at his younger age. As you can see, lateral joint space of operated knee is almost disappeared due to long-term meniscal dysfunction. Therefore, Save the Meniscus is worldwide slogan. We orthopedic surgeons try to preserve as much meniscus as possible using several meniscal repair techniques, outside in, inside out, and all inside techniques. This slide shows the number of arthroscopic meniscal surgery in Japan. As you can see, meniscal repair cases have been increasing recently. However, as reported repeatedly, one of the important problem of meniscal repair is relatively high failure rate after surgery. Silk elastin is an artificial protein which is composed of silk fibroin and elastin. We can make various types of scaffolds like gel, seed, and sponge with these materials. It is reported that silk elastin can activate cell migration and enhance collagen production. Physician-initiated clinical trial using silk elastin sponge for refractory skin ulcer has been ongoing. We believe that there must be a good possibility for meniscal repair and regeneration therapy using this material. The purpose of this study is to report the effect of the silk elastin protein for meniscal repair and regeneration using rabbit or pig medial meniscal injury model. For the first study, we created 1.5 mm diameter defect in the anterior corner of the medial meniscus of rabbits. We made 3 groups. 1, defect is untreated. 2, type 1 collagen sponge was filled in the defect. 3, silk elastin sponge was filled in the defect. We evaluated the healing until 24 weeks. This slide shows better meniscal regeneration in the silk elastin group compared to the empty or collagen group. This slide shows the score of meniscal healing until 12 weeks. As you can see, scores of silk elastin group were significantly better than those in the other groups at 4, 8, 12 weeks. These are type 1 and type 2 collagen staining. Not enough, but we can detect type 1 and type 2 collagen in the silk elastin group. We perform migration assay using meniscal cells and synovial cells. Blue dots shows migrate cells. Silk elastin concentration dependent cell migration was observed only in synovial cell group. These are immunohistological staining for silk elastin. Silk elastin is almost completely absorbed until 8 weeks after implantation. Next, we present meniscal repair with silk elastin using pig model. 10 millimeter longitudinal tear was created in the anterior portion of medial meniscus and sutured with 2 stitches using 4-0 nylon thread. One knee had repair only and the other knee had suture with silk elastin injection to the repaired site. These are macroscopic findings of repaired meniscus. Macroscopic score was better in the silk elastin group than the control group, although they are not statistically significant, probably because of small number of specimens. Now we are increasing the number of the experiment. These are histological findings. As you can see, failure rate of 4 and 8 weeks in the silk elastin group was lower than those in the control group. But again, significant difference was not observed. We are now preparing the clinical trial for the patients. We confirmed that we can inject silk elastin arthroscopically with and without irrigation saline in the pig model. Silk elastin was remained at the repair site after arthroscopic injection. Next future step should be meniscal regeneration using minced meniscal fragments and silk elastin sponge for partially resected meniscus. We have been investigating this treatment option using animal model. In conclusion, the effect of silk elastin protein on meniscal repair has been demonstrated in rabbit and pig medial meniscal injury model. After accumulating data from preclinical studies, we are planning to conduct clinical trials as a new approach to meniscal repair and regeneration therapy. Thank you very much for your attention.
Thank you very much, Dr. Adachi, for your great lecture. Now we have some questions for the auditorium, for the speakers. ¿Alguna pregunta al auditorio para los exponentes?
Okay, one question. Any questions for the speakers?
Are you there?
I'm here.
Hear me?
Hi. Hi.
Okay, thank you so much.
Yes.
I want to ask you something. In the last 5 years, I always ask about if you can use
Yes.
tunnel tibial for ACL reconstruction to fix the root, the meniscal lateral root in the same tunnel. What do you think about?
I think the lateral root and ACL tunnel is not the same. So I think we should use the different tunnel. Otherwise, you create too much tension to the lateral root. Yeah, that may cut through. Yeah. So I don't think we use the same tunnel.
Okay,
ACL tunnel is more anterior. Yeah, much more anterior.
So that's my recommendations. Yes.
Thank you so much. It's clear.
Yeah. Thank you.
There's another question at the end of the auditorium.
Yeah, hello, good afternoon. My question is for the last presenter about the silk elastin fibrin biomaterial. How long does it take for you to prepare the material to encapsulate the cells to inject it back into the meniscal defect? And have you thought about a one-step process of the shelf to do the same procedure during the length of the surgery so you don't have to go back to the cell facility to create the scaffold and the cells?
Okay, thank you very much for your question. The silcorasin is the artificial protein, and we can prepare the protein intraoperatively, so we can inject the protein directly to the repair side. Because this is just the protein, so we can prepare the materials beforehand. Am I answering to your question?
Yeah, so to follow up that question, how long does it take for you to prepare that process? Do you do it at the same time as the surgery, or do you have to go back to the cell facility and create
No, we don't need to use the cell facility. We can prepare at the same time of the surgery.
Okay, thank you.
Okay, thank you very much. We are on time, and our speakers are from very far away, and we want to thank you a lot for being here at this time. Perhaps the last question? Okay, sorry, well, one question more for the speakers. You are very kind to be now connected, please. Thank you.
Yes, centralization is a new alternative. What is the indication in the centralization meniscal? What is the difference in transplantate or meniscal allograft in when do you use centralization?
The question is from Dr. Kim or Koga, I think. Koga.
Okay, so for me, I don't do meniscal transplantation because in Japan it's not possible for ethical reasons, but centralization for extruding meniscus is applied for the cases with extrusion more than 3 millimeter, or the cases with the tear causing extrusion, such as radial tear or posterior tear, which is caused by the meniscus degeneration to augment the to reduction of the centralization, because in degenerative cases, just repairing the torn meniscus is not enough to secure the torn site itself.
Okay, thank you very much for your answer, Dr. Koga, and we want to thank you very much for this excellent symposium. And we're very kind to be connected at this time. So thank you very much. Dr. Lee, I know you want to say something.
Oh, thank you for having us. Thank you. Yeah.
Thank you.
Bueno, muchas gracias por la asistencia al
Thank you so much for attending this symposium, this third symposium of ABCAS with SLARD. Now we're gonna
presentar en 2-3 minutos, ya vamos a comenzar. Bueno, vamos a darle comienzo para cumplir los horarios.
We are about to start with the work associated to this room. We are going to start with the first presentation by Dr. Luis Antonio Goitia, the proximal osteoarthritis for the treatment of arthritis in the knee, and also Dr. Juan Felipe Fernandez to be able to comment. Dr. Goitia, welcome. Okay, good afternoon. Okay, thank you very much. My name is Luis Antonio Gotia. I come from Sucre, Bolívar. I'm going to treat the medial osteoarthritis in the knee. We know that to treat the degenerative osteoarthritis, there are many options, amongst which we have the proximal osteotomy of the peroneum. And as we can see in the literature, the idea is to determine this for the treatment of the medial and to assess the functional and clinical outcomes. And for the work, we included 10 patients, and 8 of them had unilateral involvement and 2 bilateral involvement between March and April. And the criteria accreditation was osteoarthritis in the medial compartment from degrees 2 and 4 according to the classification. And the exclusion criteria were as arthritis. For the surgical, the patient was under, and we marked the fibula on the skin, and we did a lateral approach and posterolateral approach between the soleus. We did an osteotomy from 6 to 10 centimeters from the head of the fibula, being able to resect 2 centimeters from the fibula. Once the procedure was done, we closed it according to the planes without drainage. Then we allowed for walking once the pain went down. We did the follow-up at 12, and the average was 65 with a range from 59 to 78. The classification of Clovelin-Lawrence, some of them are grade 2 and 4 of such classification. For the measurement of the outcomes of these techniques, we took into account the radiological and clinical aspect. Regarding the radiological aspect, we measured the femorotibial aspect and also in the tibia, we were able to obtain an improvement of 4 degrees, and in the lateral, with a reduction of 4 millimeters, as we can see in the progression of the X-rays. We can see the 2 videos when we talk about the clinical aspects. With regards to the clinical aspects, we take into account the Alliance Society scales, and we also took the VAS, where we were able to obtain 40 points of improvement in the first one, and to reduce from severe degrees to moderate and mild in the second scale. All these 2 outcomes are statistically significant. This technique we started to see the first reports of this literature in the year 2014 and 2015, both for Hindi as Chinese authors, as we can say over here. And from there on to currently, we have more articles in literature, but obviously with a level of evidence which is still low, as we can observe over here in this reviews and even this last one that appeared almost a year ago. What is this technique based on? What are the principles? Well, we're going to name we can say that there's a lower density in the medial compartment of the knee. That's why the degenerative arthritis allows for the deviation of the knee, and that's why there is a more density in the head of the fibula and also in the lateral compartment of the knee. If we remove one portion of one bone block of the fibula, we are able to balance this inequality. Another principle in which this technique is based is that the medial aspect is based on 1 pillar. However, the lateral by 3 pillars, 2 from the fibula and 1 from the knee. If we remove one bone block of the fibula, we balance this inequality. There are two theories of the displacement. This modular competence of the biceps, fibula, and soleus makes the head of the fibula displaces laterally. This displacement causes a reduction of the lateral compartment and an increase of the space of the medial space. Okay, the osteotomy, it's a new therapeutical approach for degenerative arthritis of the knee. There's a low level of evidence, but the outcomes are good in the short term. I talk about 12 to 18 months. And the most, we can see that there is a relief of the medial pain in the knee. There's an increase in the medial space. We're going to better walking and better radiological results compared to the total knee arthroscopy and the tibial osteotomy. We can say that this procedure is less expensive, and this is very important in developing countries and where the access of medical insurance is probably very difficult, as it happens in my country. We can see there's low mobility and there's no need of placing implants. And if this technique fails or the results are not don't last in time, it can turn into a total arthroscopy of the knee when deemed necessary. The limitations of the study, well, we can say a higher level of evidence. Not only this, but in the current literature with a longer follow-up, the long-term results are still uncertain, and the ones that go beyond 2 years, and we don't report the effects that may happen in areas like the ankle and the hip. Thank you. We're looking for Dr. Felipe Fernandez. Okay, first of all, I would like to congratulate you for your work. I think that it's a very interesting technique to be able to consider with the patients that have a lateral laxitude. I only have one question, and it's that knowing that the patients tend to move sideways and the lateral work like a tension, both the collateral as the femoral biceps. When we do the osteotomy between the fibula, and I don't know what's the role of those structure, because the insertion is more proximal. Therefore, can you please clarify this comment? Oh, yes, because of the principles that are described in the literature that are based to apply this technique. We can say that one of them, it's the muscular attraction or the competence that we have between the biceps and the soleus and the fibula. On the other side, we can see that after the proximal osteotomy of the fibula, there is a sliding of the head of the fibula with regards in the proximal joint, and this sliding causes a reduction of this lateral space and an increase of the medial space. And in this space, based on these principles that we have this theory and this surgical technique. Okay, but in the surgical techniques, would you have to affect the proximal fibula, or to just do the osteotomy below the head, and only the dynamic forces make this to have any kind of progressive lesion? Only the dynamic forces, yes, because the joint is not touched.
Próximo trabajo. Técnica y resultados de nuestros pacientes con enfermedad de Hartmann. Presenta el doctor Cardón.
Bueno, gracias por la invitación. Bueno.
Okay, these are the results of our endoscopic calcanoplastic procedure, and a brief summary just to remind you what it is. There is there's a mechanical prominence accompanied by pain and bursitis, which is generated by tendon flexion and also apoptosis. Okay, the study is retrospective with all of the patients surgically intervened up to March 2020. We had 14 patients, and the inclusion criteria is patient with Hablum disease and who had at least one conservative treatment over the past 6 years before surgery. With regards to the exclusion criteria, all of these were patients not surgically intervened or those with neurological injuries. All of the patients before the surgery were subjected to an evaluation according to location of the pain, lateral, medial, central, or in all of the posterior region. And all of this was evaluated through the analogical scale. All of the patients before surgery were given X-rays to confirm the apoptosis and also to determine the importance of doing a pre-op MRI where we can identify how the tendon is doing and the mechanical apoptosis and the bursitis due to pressure. Before the operation, all of the patients were subjected to the AOFAS scale, as well as the postoperative, post-surgical complications, and two subjective questions were asked about whether or not they would decide to be operated on and the degree of satisfaction regarding the surgery. As for the X-rays, they were done from 1 to 6 months to determine how much exostosis had been resected. And also all patients 3 months later were given an MRI to look at the tendon, the degree of the resection provided, and whether or not they could go back to sports activities after the resection of the exostosis. The surgical technique uses two distal approaches. The posterior one on the ankle, it is not drop as such. So what we do is resection of all of the synovial region and the bursitis to be able to identify, as the picture shows, the Achilles tendon and the exostosis, and we can identify in the picture the resection of the exostosis, and we can also identify the picture to the right, the retrocalcaneus space, which is going to serve as a parameter. We don't know how much needs to be resected. That's why we provide this space at the Achilles tendon, which is the resection cap before insertion.
La técnica de resección, que puede ser con burr, shaver, y cómo nos podemos meter.
The resection technique, which can be done with a shaver in the retrocalcaneus space to approach all of the exostosis. And as a result of the study, follow-up was provided at 40 months with a minimum of 18 months. All patients suffered from tumefaction for about 2 months, and they were all provided kinesiological follow-up. There was no difference between one side and the other. Now, the lateral side was more frequent than the medial or the central side, and that's important because that's the area that generates most flexion. As for the outcomes, based on the evaluation, there were no significant findings with a reduction of pain, which leads to good results for this technique. And as for the satisfaction or whether or not the patients would decide to be operated on, the rate was 80%. The 2 patients said that they were not happy about the operation. One of them could not regain his mobility, and the other one suffered from long-term discomfort, so they were not very happy about it. all of them basically were satisfied about the type of surgery and the aesthetic appearance. Now, as for the bibliography, there isn't much. There are some publications, and all of them agree that outcomes are good, and the open techniques provide good endoscopic results, as well as the scores, a high rate of recovery, the resection of exostosis as provided by these techniques. This is a scheme of the publications, including ours, which is the latest one, comparing this, despite the fact that our caseload is not very high. It's actually similar to other authors. All of them agree that the complications are basically the same, and the outcomes are also the same, as we can see here. Some agree with the OFAS score in terms of evaluating the patients after the surgery, so the results were matching. As a conclusion, the arthroscopic techniques associated to small scale approaches, higher visualization of the affected area, fewer complications on the injury, better aesthetic results, less recovery time, reduction of mortality, less pain and inflammation after the surgery, which allows for the patients to go back to their activities faster, and the probability that it is an outpatient practice. What we do need to take into account as for this technique is that it is not good for every single case. Probably with intratendinous calcifications, this is not the ideal technique because these calcifications cannot be resected. As the study says, it is retrospective with a small number of patients and with strains, good follow-up, and several subjective scores and evaluations. Thank you. Okay, Dr. Cardon, thank you for the presentation of this excellent work. Okay, is Dr. Pastrana in the room? Okay, one question. Okay, you mentioned that you get the distal insertion of the Achilles tendon as a guideline to see how far the resection goes, but what is the guideline on a proximal basis, and do you use imaging for debridement? Okay, well, I didn't mention it because I didn't want to address that particular technique, but we always use imaging, and the reality is that what we have to resect, that's why it's always important to look at the area of pain because it indicates exactly how far the resection should go, lateral, medial, central, and also as a reference point, because one of the biggest complications reported by open techniques is the excessive resection of exostosis, which may release the tendon, and that's a tear by insertion. That's why the risk, of course, there are some angles that have been published, but they are not very useful. So that's why we took that retrocalcaneus space as a marker, and when the real insertion begins, that's a space where we can go in between the tendon and the exostosis. And when that insertion begins, which is already attached, we don't resect any further. We always leave a clean edge so that pressure will not be generated on the tendon. Okay, good afternoon. I truly liked this work. I thought it was quite original. I've worked with Dr. Ibrahim for quite a few years. We did endoscopy work on the Achilles tendon for tendinosis, and he's a precursor of that. Okay, is this disease associated with tendinosis? And we place the patient face down, we go posteriorly. So have you done any type of lamination of the tendon to cure the tendinosis, which is something that we do? Yes, what we do is that if you get a synovial, it's perfect, and there is nothing wrong there. But if there is synovitis or debridement of the tendon, we usually do shaving or like a cleanup. Now, in reality, it depends on the case. When it's very advanced, that degeneration ends up becoming calcification, and it becomes an insertional pathology of the Achilles tendon. That's why I said that the indication is important, and that's why identifying when it's Haglund and it's associated to an insertion, and we need to take that into account because it's different. The important thing is to determine that it's generated by the exostosis friction, the bursitis, and it's not the same because the outcomes are not the same. But when we look at inflammation or some sign of tendon injury, we do a cleanup, but no more than that. Resecting an osteophyte or something like that would generate a significant injury of the tendon with a tear. Okay, let's continue with the next work, degree of satisfaction in functional outcomes in total knee osteoplasty, comparative study between conventional approach versus robot-assisted approach by Dr. Figueroa.
Mientras nos
Well, the fitness doctor, Joan Lea from Spain, is he from Spain? Is he in the audience? Good afternoon, and thank you so much for the opportunity of presenting our work. Okay, studies about the total knee arthroscopic with robotic assistance have showed promising good term outcomes. However, the literature can be non-representative because it comes from Asian and Anglo-Saxon countries. Also, in Latin America, we don't have comparative studies in patients with total knee arthroscopic that have been operated with conventional surgery versus robotic arm. That's why the idea is to establish a comparative analysis of the satisfaction and functional parameters of patients operated from a complete knee arthroscopy in conventional with conventional surgery in comparison with robotic arm. This is a comparative study of a prospective cohort consecutive after 1 year follow-up with the inclusion criteria with patients with a very severe symptomatic knee arthrosis and the deformities where the plexus deformities and also incomplete follow-up. The patients were subjected to a total primary knee arthroscopy initiated in 2018 in a consecutive manner, first with a conventional technique and later on with a robotic arm from 2018 to 2020, in which all the surgeries were performed at the same center and with two surgeons that have more than 30 years of experience in conventional techniques and also in cadaveric training and robotic assistance. And all the patients received the same rehab protocol. And they were assessed with pre-op surveys after a 1 year follow-up, where they were able to obtain demographic data and also the satisfaction and expectations of the patients through a very specific survey that was done at our center. And the results were reported by our patients. Okay, with regarding to the satisfaction scale of our center, this is a 5-question survey, and that compares the private status prior to the surgery now, the functionality of the limb, the capacity to perform daily activities and activities with higher intensity, and if they would go back to the procedure again. And regarding the analytic analysis, we did Poisson and Fisher for a 5% significance. We also did a post hoc analysis of each test to be able to do a total significance more than 80%. Okay, with regards to the outcome, more of the patients were female, and the average age was 67, and there was no significant differences between both groups. When we talk regarding surveys, we can see that in the group, the robotic arm had a very significant improvement when compared in two groups, and the difference was statistically significant. After that, both groups improved in a significant manner, without difference in both groups, however, with a trend to have a higher improvement in the group. And then after the submental divisions, there was no difference between groups. And finally, when we talk about the physical subdivision, we can see that both groups improved in a very significant manner. And also it improved in a very significant manner the group with robotic assistance. Okay, regarding satisfaction, all the patients were able to obtain a very high degree of satisfaction, 22, 24 points out of, from a total of 25, with no differences between both. With regards to the discussion, we're going to, we see this work of Marchand in 2016 with a 6-month follow-up that shows less pain, better self-reported results, and better functional in patients operated with a robotic technique. This is very similar to a study done with our group from 2020, where we can see the immediate post-op results, and we can see that the group with robotic assistance has a lower level of pain, and they were able to deambulate earlier after the surgery. And then we have this work from 2016 that assess after 2-year follow-up. We can see the SURF 36 being able to see higher vitality in the patients and a better emotional performance, which matches our study, and it's very promising. Okay, this is the very first study to assess satisfaction in patients, and with total prostheses, and also was a comparative and prospective study. And the mobility or study, it's survey, it's not validated, but it's in the process of being validated. Our sample, it's small, but it has a very statistical power. We can say that total knee arthroplastic with robotic assistance had better levels of mental health and higher satisfaction regarding functionality, and when compared to the conventional technique in this clinical series. Thank you so much. As we don't have, does somebody want to make any comment or question? Okay, very clear presentation. Okay, my question is, for example, when we talk about surgery in comparison, or if there is a kind of complications of the robotic surgery, can you please tell us something about complications or time? Okay, thank you so much about the questions. Okay, maybe Dr. Calvo and Figueroa that are maybe can answer to your questions better than I can. Dr. Calvo. Okay, it's all okay. Of course, all these things have a learning curve, and we also analyze the curve itself. And in our specific case, we last the same between conventional surgery when compared with a robotic surgery, but the learning curve, it's more or less a year. And when you talk about your progression, and initially the times were higher with robotic, which is part of the learning curve. However, there were no complications, but of course it took us sometimes up to 40 minutes more than a conventional surgery. And those, however, we started shortening those times, and after 3 months, we have a non-significant difference between the two, and currently there is no difference between the two techniques. Okay, thank you so much, Dr. Calvo. Anybody else wants to make a comment? Okay, thank you so much, Doctor. Thank you. And we've finished with this part of the event, and we're going to have a coffee break and at 4:30. And we will continue at 4:30 with the next presentation. Thank you.
Buenas tardes. En honor al tiempo vamos a empezar. Vamos a hacer una presentación de dos trabajos del grupo.
Okay, good afternoon. From German clinic in Chile, the first one of them is the return to sports of patients with ACL review surgery. The second one is the evaluation of the anterolateral ligament on the knee by MRI. It is a predictor of failure of an ACL reconstruction. There is a small group of people here, but I would like to take 1 minute to say that it is actually a milestone at the Latin American Association for Conference to have gotten 100 different works. I believe that the next step of the Latin American Association is to bring stars to talk about their experience, which is also important. I believe that the challenge presented to Latin America is publications. That's why this space, and I thank everyone attending. You recognize the real importance of this conference, and I say this as a scientific director of the event. So welcome, please go ahead.
Muy buenas tardes, mi nombre es Javier.
Good afternoon, my name is Javier Gonzalez. I come from Clínica Alemana. Today I'm going to talk about our work on return to sports by patients of ACL reconstruction. I have no disclosures, and by means of an introduction, the return to sports is a key indicator of success in patients subjected to ACL reconstruction. Review versus primary reconstruction. There isn't much literature in this regard, much of which is in English, and the purpose of the study is to evaluate the rate of return to sports, the frequency after an ACL surgery in a group of patients operated on at the very same center. The materials and methods, this was a retrospective study on data collected from 2009 to 2020, and we had 124 patients with ACL reconstruction review by email and by phone interviews. This was an ACL surgery review at the very same center and operated by the same surgical team. As for the purpose, there was an evaluation that could lead to the results. Demographic data on the patient were collected along with Cincinnati and Techner scales, type of sports before the injury, type of sports after the injury, and the time to return to a sports activity. Okay, these are the outcomes. The average age of our patients was 27.67 years. Males were predominant. The sports before the lesion, about 70% of them were active in sports, and after the review, there was a reduction of patients up to 89%. The registered time of return to sports was 9.55 months. As for the scales evaluated, both dropped as expected. The Cincinnati rate dropped up to 80.9 after the review, and Techner from 6.6 to 5.3 after the review. Both were statistically significant. With regards to the sports practice before the injury, the most frequent one was soccer, which considerably considerably dropped, and tennis was actually more frequent as compared to the latter. Okay, a little bit of discussion. The reconstruction of the ACL affects the level of return to sports activity, and patients actually go back, but when they go back, they are active more briefly. Okay, they were actually amateur sports players. There was the level of functionality, the type of sports that they played, some of the strengths of our work. Okay, they were basically low performance patients. They were amateur sports players, and we took into account the previous level of activity and the type of sports. The study was retrospective. With basically 124 patients. As a conclusions, the ACL review surgery allows for proper return to sports for most patients, but it requires a change in the sports attitude. It's not the same sport or at the same level as previously. Thank you. Okay, I'd like to ask a couple questions with regards to the work. Okay, the control implemented was by phone interviews, yes, and also review of clinical history. So we don't have an evaluation of the level of stability of the patients. No, that was not really part of the study. I believe that it is important to include, and it's also important to see if some kind of an action was made on the lateral and anterolateral side in ACL review surgery. Is it a routine for you to address these anterolateral cases? Okay, it is routine, but it was an issue because it was done in the very last minute. We looked for patients up to 2009. So it was not a routine procedure previously, but now it is. Okay, I believe that this work is highly valuable because we can actually respond to patients once they ask after a review surgery whether or not they can go back to the sports activity. This somehow confirms what we see on a daily basis, which is that amateur patients don't usually go back to the same level, but a high percentage of them actually can change sports activities and probably get into sports that are not very pivotal. I would like to know some of the conditions of the review regarding the state of arthrosis, the meniscal condition, and what type of technique was utilized so that we can have a better outlook of these outcomes. But I believe that the comment is absolutely favorable, and it helps follow a pattern of behavior when patients ask if they can go back. That's the kind of questions they typically ask. Thank you.
Our next presentation, which is the assessment of the interlateral ligament of the knee through MRI. Is it predictor of failure of the ligament? I think that this is a work that continues its correlation with the previous work of the Clinic Alemana. It's very important for you to know that this comment, this is not assessment of the work. It's just a personal for someone that works on the knee. I think that the assessment of the work, it's followed by a group of epidemiologists, by part of SLARD, that does a much more objective assessment because, of course, there's an award and okay, once again thanks again for the opportunity. Okay, the main issues when we're working on the reconstruction of a ligament, it's when there's a failure of the graft and the persistence of the rotation. Now, the predominance of the ligament and the rotational stability, it's that many groups consider whether we need to do an anaplasty of the ligament in the case when there is a lesion of the ligament. However, despite all the studies, and because there's a controversy in the same conference, they're consistent. When do we do a plasty of the lateral ligament, and we need to know if this ligament can be accessible through MRI. The goal of our work is to assess if there's tears in the ligament in MRI. It's predictor of a failure of a reconstruction of a primary anterior ligament. The thing is that when we observe a tear, it's associated to a higher failure rate of a reconstruction of the primary anterior ligament. This is a retrospective cases and controls. As the inclusions, we have we can see the MRIs, the same MRI techniques, the same center, the same surgical team. And as the exclusion criteria were multi-ligament lesions, procedures in the cartilage and series that required correction. Okay, we selected with patients with an anterior ligament where we did a primary reconstruction with a plasty of the anterolateral ligament, and we used as cases the patients where there was a failure in the reconstruction, and to control these patients with a failure in the reconstruction. Okay, then if we can see, if we go back to the study, we wanted to assess the study to be able to see the partial visualization and a complete visualization of the anterior ligament, the visualization and the degree of the lesion. To be able to define the rupture of the anterior, we use the degree, we use 1, 2, 3 as a way to increase it, which is what we've seen here. And we can say like the tear of the ligament when it's degrees 2 or to grade 2 or 3. Okay, when we also did a pilot screening for the sensitivity and the specificity to be able to visualize the tear of the anterolateral ligament. And here we can see a logistical regression to be able to calculate the odds ratio between the failure and the. We were able to cross an N6 with a power of 80% and a significance of 70%. When we talk about the outcomes, the control groups had a mildly case of rates, and there was a very statistically significant difference. Most of the patients were male, and the graphs were metastosilids, and these factors don't show difference between the groups. When we talk about the pilot screening, the sensitivity and specificity for the tears of the anterolateral ligament was 67 and 73% correspondingly. When we talk about the visualization of the anterolateral ligament, we were able to visualize it in a partial manner in 100% of the cases, in a complete manner in 35% of the cases. And in a primary outcome, we can see that the tear of the entire ligament in the MRI, it's significantly associated to the reconstruction of the primary anterior ligament with an odds ratio of 1 point. And when we adjust for 8, we can see that there's still statistical significance, but the odds ratio drops. Okay, when we talk about the visualization, we can say how this study of 2018, where we observe very similar results to the ones we have with a partial visualization of the ligament in 76 to 77% and a complete visualization between 10 to 72% with regards to our primary outcome. We have this RCT from 2020 and a systematic review in 2018 when we visualize anterolateral ligament to the reconstruction of the primary anterior ligament. We reduce the reconstruction rate, and we reduce the stability, which matches our study. Finally, we have this group of 2018, a retrospective study, which is very similar to our study that wants to look at an association between a failure in the repair and the tear of the ligament in MRI. However, they didn't find significant differences. As a strength, we can say that it's the second study that assessed the anterolateral ligament and MRI in association with failure in the reconstruction, but with a change in behavior with regards to the prevention of failure of the reconstruction, and the methodology is adequate. And with regards to the flaws, it's a retrospective study, and it's very small despite the fact that it has the statistical power, but we didn't study other things associated to the reconstruction of the ligament. As a conclusion, we can say the visualization of a tear of the anterolateral ligament in MRI, it's associated to the risk of failure of a reconstruction of the primary ligament. Okay, in knees, there is a very controversial topic whether we should reconstruct the anterolateral ligament regarding the technique, either a pure reconstruction or to be able to do a tenodesis, or even of the ones, the most common would be, of course, it's the lemur surgery. It's the most common one. There are some factors that are formally associated to failures and that need a clear clinical indications about some gesture of the lateral structures. And we have the pivot patients, young patients, hyperlaxitude patients, or high performance sports people. I think that this is a very interesting work because it would be maybe in the following some prior work, it would be the assessment, the objective assessment of the need of doing some kind of actions about the anterolateral structures. I think that the work has a lot of validity, and I think that it's well defined. And I would like to know the type of sports because it's different when we talk about the risk and pivot sports than the ones that not. But of course, it reinforces the fact that we should give a critical relevance to the assessments of MRI assessment in these patients. I think that no patient is operated with an MRI. Therefore, we have this tool to be able to define in those patients that are in the gray area. And I think that you all agree with me that those patients that have an explosive pivot shift, that are chronic or that are high performance sports under this characteristics, there is no doubt. But there is a very important group of patients in a gray area where one needs objective elements to be able to offer what's best. And I think that the outcome, it's striking. I still don't know the epidemiological study, but I think that it's very valuable. Thank you so much. And I would like to add that, of course, on our side, our idea is, of course, to train musculoskeletal radiologists to be able to see the anterolateral ligament and focus it, because sometimes there are people that focus it at the moment of reporting on the MRI. Of course, of course. I don't remember reading, for example, in my institution, I don't remember reading where, despite the report of the lesion of the ligament, the impact on the cartilage and the meniscus make a reference to the structures or the anterolateral ligament. Can I ask you a question? Do you firmly believe that there's the anterolateral ligament? Do you believe in it? That's what our work is about. That's why it's so controversial. I think that it's extremely valuable, and thank you so much for your presentation.
Muy bien.
Okay, at 5 o'clock, the high lecture will begin. We have 4 rooms. However, in 2 of the rooms, a group of high lecture colleagues will be doing the presentations. In another room, yet another group of important guests are scheduled to talk. So we invite you to attend these outstanding talks, not only about medical issues, but also philosophical issues from people with lots of experience and with a lot to tell. Thank you.
guess.
Okay, good afternoon. I have the honor. This is an experiment at SLARD this year.
Este es un experimento.
This is a wonderful experiment, which is going to ever after be imposed on our association. I have the honor of introducing Dr. Tobias Young, who is going to talk to us.
Lesson learned by more than 20 years of osteoarthritis. Thank you so much.
So, hello everybody. Thanks a lot for giving me the opportunity to give this talk, for the invitation, Paolo. And it's always a pleasure to be here in Colombia. It's already my third time being in Cartagena, and I've stayed several times also in Bogota, giving some cadaver lectures and courses. So, alignment takes it all. First of all, I just want to present where I come from, Berlin, the main capital of Germany. It's not only the main capital. I'm coming from the Charité, and it's the biggest university hospital in Europe. And I'm head of the department for sports trauma and knee reconstructive surgery. So I was asked to give a certain talk about my experience, an overview, maybe with some philosophical pictures as well. I decided that osteotomy is a good discussion point, and I think this picture, this slide, what you can see here, describes already all the different topics and all the different pathologies we have to address in osteoarthritis and ligament instabilities, cartilage, and meniscus problems. And attending to the talk, the main thing we're talking about is what you can see here. These are 4 different cases, all presenting different pathologies, different reasons for performing an osteotomy. First of all, we have to talk about some really important persons for osteotomy. J. Simon Lau already described a couple of them. This is Mr. Coventry, of course, then Draw Paley, giving these principles of deformity correction. That is always a book that is really important, and also it's I love to read it. And then some German colleagues, Philipp Lobenhofer, I think all of you will know him, and Wolf Strecker. Do you have a different one? Sorry for this. So it's in this case, like in surgery, if you have a problem, you have to solve it. And be patient, of course. So Wolf Stecker, he's often forgotten, but he's quite important for, at least in Germany, for osteotomy, for indications and planning of the correction. So in the beginning of my experience with osteotomy, so at the turn of the millennium, osteotomy was mainly a discussion for unicompartmental osteoarthritis. So it was a discussion between unicondylar and medial open wedge osteotomy or lateral closed wedge osteotomy. But is this really a discussion? Is this really a technique for the same patients? This is something I want to describe with the upcoming slides. So first of all, talking about evidence, it's always a thing, what you can see here. Evidence, especially in scientific literature, is sometimes really hard to understand. And if you want to compare unicondylar versus HDO, for example, there are only a few studies really describing the pathologies well enough that you can judge about is there any improvement by using unicondylar versus HTO. So the other thing is between 2000 2010, due to the success of total knee replacement, we saw, this is a Scandinavian register study, what you can see here, there was a decrease in surgery for osteotomy in unicondylar just because of the success of total knee arthroplasty. So this decade is already gone, and this is best described by the fact that we are always discussing two different things, and the indication for osteotomy is the main important thing, and that we learned quite a lot is described at the fact that you can see here in the PubMed. In the first 70 years, between 1950 up to 2000, there have been only around 1,000 studies published about osteotomies, and within the last 20 years, you just see that we have 3 times more of these studies published. And if you see over the just last 2 years, you can see that we have nearly 1,000 studies published for osteotomies around the knee. So alignment matters, obviously, and you have different indications and different pathologies. The guidance and stabilization of the knee is mainly due to active stabilizers, passive stabilizers, and of course, static stabilizers. And if you have, for example, any kind of ligament injury in combination with a malalignment, it is not that obvious that by just only addressing the ligament insufficiency, you will just gain back the same result as before the injury. So in this case, valgus malalignment together with a medial collateral injury in combination with an ACL, you will have a difference between patients with valgus and varus malalignment. So to get this complete harmony in movement of the knee joint in combination with the ankle and the hip is always something you have to see in combination. Don't look only for the knee joint. It's always something that you have to address also is the ankle and the hip joint. And it's best described with this kind of dancing video from the meeting in Argentina, that the knee function is a combination of the hip, ankle, and knee joint, and of course in all the active, passive, and static stabilizers. So this is a case describing everything about osteotomy. This patient, 39-year-old lady, suffered an ACL injury at the age of 12. Then she got an ACL reconstruction by a knee specialist. This guy was harming the proximal growth plate of the tibia, but all the other doctors performing surgery on this knee within the last 10 years were only looking for the ligament insufficiencies and not looking for the bony malalignment. Even my former mentor was doing twice an ACL reconstruction and not looking for the sagittal plane of the tibia. So now, with our knowledge now, it's quite obvious. So in this case, for example, valgus malalignment with a recurrent ACL instability and a loss of the lateral meniscus, only addressing the ligament, doing another ACL reconstruction won't be enough. So first of all, we had to address the malalignment, of course. We had to do a one-stage femoral osteotomy together with a reconstruction of the ACL using the quadriceps tendon and having this result. So recurrent ACL instability is a good topic to talk about osteotomy, because in recurrent ACL instability, for example, we have no generally applicable guideline. The knee kinematics are only incompletely restored. And of course, everybody thinks about additional injuries like the posterolateral corner, medial collateral ligament, meniscus, cartilage. Everybody's thinking about the surgical techniques, tunnel placement, graft, auto versus allograft. patient compliance, then after treatment, of course. But still, if we address all these important factors, we have the problem that we have still a high percentage of recurrence of the ACL instability after revision surgery, around 25%. So talking about the sagittal plane seems to be of major importance, and this was already described in the arthroscopy, in this kind of review, 2016, that a slope steeper than 5 degrees is a reason for recurrent ACL instability. So what is the slope? Because HGO osteotomy is not only the coronal plane, of course, it's also the sagittal plane. Slope is in the function obvious, too much information for the computer. So if we have a regular slope, then on the left side, you can see the flat slope. With a flat slope, the tibia is pushed backwards during the kinematics of the knee joint. So this is good for the ACL and bad for the posterior cruciate ligament. In a steep slope, the femur is pushed backwards or the tibia is pushed anteriorwards. So this is good for the posterior cruciate ligament and bad for the anterior cruciate ligament. So obviously, this is of importance for our ACL reconstruction. So again, alignment matters. So we already know by several studies published within the last 5 years that we have a correlation between a steep lateral tibial slope and an increased ACL rupture, especially in children. We also have a correlation between a steep slope and revision ACL surgery. We have another one that's really not working quite well. So we have a correlation between the graft survivorship after anterior cruciate ligament and based on the tibial slope. This was published by a group of Clemens Gwinner, a former resident of mine, and Andreas Weiler. They have seen just a correlation between the numbers of ACL revision surgeries and the degree of the tibial slope. So this is an example, first case, male, 37 years old, police officer, suffered a lateral collateral injury in 2014. Refixation was performed in a quite experienced hospital in Hamburg. Then 2016, another ACL injury. And since that time, the patient suffered with recurrent instability, pain under weight bearing, effusion, and swelling. Important at this case is not only that he has severe cartilage damage of his lateral femoral condyle, a flat tear of the medial meniscus, also with some chondromalacia. The thing is that he had a slope of 12 degrees. And in this case, with radiographs, with the Telos device, you've just seen the riding of the femoral condyle just at the backside on the tibia. So he was nearly subluxating his tibia. So therefore, we performed a slope correction. These are the arthroscopic pictures. What you can see here on the left side, the lateral femoral condyle, on the right side, the flap tear of the medial meniscus. So we did a correction of 10 degrees of the tibial slope. And of course, we also tried to do some correction of the coronal plane, but due to the fact that he already had some progressive chondromalacia of the lateral femoral condyle in combination with the medial meniscus flap tear, the area where we could just end up with our coronal correction was quite tight. So this was after the correction, and this was before the correction. So you notice that we just did a correction of the VAS of only 3 degrees due to the cartilage damage of the lateral femoral condyle. Another case, so of course, tibial slope is not only corrected for anterior cruciate ligament, it's also corrected for the PCL. It's also a study I performed with my group together. There's a correlation between the success in PCL surgery and the slope. So 4 to 5 year old female, medial osteoarthritis with a chronic PCL and posterolateral corner insufficiency. We performed in preparation for the ligament reconstruction, this HTO, but after 1 year after this osteotomy, she was nearly free of any weight-bearing pain and was not experienced anymore any kind of instability. So she was not in the mood for ligament reconstruction. Another case with recurrent PCL instability after an isolated PCL reconstruction, you can notice the femoral bone tunnel over here. Also with a slope of only 4 degrees, we just increased the slope of 8 degrees. On case 4, this is a reduction. This is also an increase of the tibial slope. It was a chronic PCL insufficiency in combination with a hyperextension of 15 degrees in a 20-year-old female. We just performed an increase of the tibial slope in a matter that we also had to perform a tibial tubercle osteotomy, and then with the plate and with a screw fixation for the tibial tubercle. So a steep slope is in combination, or there's a correlation to the increased anterior drawer. A steep slope has increased risk for non-contact ACL injuries. Slope correction will end up in a reduction of the posterior drawer, and the steep slope is increased risk for recurrent ACL instability. So the limitations, of course, of all these studies is that we've seen different patterns of injuries. We have a missing clinical correlation. There are no PROM scores. And of course, the slope calculation was performed by X-rays. So of course, I perform in my department not only osteotomies due to ligament instabilities. We have also malalignment in case of this kind of phosphate diabetes with necessary femoral and tibial osteotomies, of course. We have this kind of morbus blount. Morbus blount at the age of 32 is a bit different than during, like, for kids or during the adolescent age. So I was quite satisfied with this kind of correction. Even now you can see that the tibial slope is not corrected in a way that we normally think it will be sufficient. So this case, male, 49 years old, 12 degrees of varus, correction of 14 to 15 degrees, is something you can learn quite a lot. Normally 10 years ago or 15 years ago, we would have only addressed the tibial side. But if you see, we need a correction of 14 degrees with only a tibia vara of 6 degrees. So the correction would have ended up with a joint line like this. And this would have been a catastrophe for the patient, of course. So back to the beginning, we had to plan bisegmental osteotomy, closing wedge osteotomy of the lateral femur, and an open wedge osteotomy of the tibia, ending up with this result. And just coming up with the last case, quite interesting case. It was a Danish national handball player, 24 years old, suffering a medial collateral injury 1 year before ending up in my outpatient clinic. He tried several times coming back on the field. He played quite successful, but he always ended up with swelling and diffusion. And during the analyzing of the pathology, we just have seen that there's not only a medial collateral ligament injury, he also had a chronic insufficiency of his root of the lateral meniscus and chondromalacia of the lateral femoral condyle. So this was the first picture of the arthroscopy. This is the second one. And this is the chronic insufficiency of the root, posterior root of the lateral meniscus. And this is the cartilage damage of the lateral femoral condyle. So 24 years old, national handball player, earning much more money than I'm earning in my hospital. So it's quite of some importance for him just to get back on the field. Of course, you can discuss what kind of osteotomy, if you see his tibial varus, you could perform. There are several studies describing that in professional sports, women and guys, HDOs will end up that they will end their career. Closing wedge osteotomies of the femur are much more forgiving, in my experience. So we planned for, in his case, different options. You can choose on your own what you have done. A is just exclusively addressing the cartilage problem. Then B would be root refixation with cartilage treatment. C with HDO, then with root refixation, cartilage treatment, then distal femoral osteotomy. And the other one could have been, of course, no further treatment, just injections and trying just to bring him back on the field for another 2 years. However, we just planned this one, doing the correction. And the reason was why we were not going for the tibia was that he already had a varus alignment of the tibial head. So we should address the distal femoral part. So we were planning a femoral osteotomy. It was just beginning in the beginning, first stage during the surgery. And the second stage was then the root refixation. What you can see here, going with an ACL aimer to the root, then drilling, grabbing, of course, and then you should always use for the posterior root of the meniscus 2 sutures. One just really at the back where the fibers are sitting, and then just in the front just to pull in the tip of the root into the tunnel just to get really a strong fixation, what you can see here. So first the femoral osteotomy, then second the root refixation, and third then the matrix, the autologous chondrocyte implantation was performed like this. So this was the end picture, what you can see here. So causes and consequences of osteotomies, of course, if you see a soccer player with a varus malalignment, we know that going for any kind of HTO will end up in reduced playing time, reduced points, and going for the distal femur, in my experience, is something that could improve everything. And having malalignment and cartilage problems, you should just remember it's not enough only addressing the cartilage. You always have to address the malalignment as well. And this is already underlined with the studies over the last 3 years that having a combination of osteotomy together with ACI will improve the general outcome of your patients. So as a take-home message, no case is like the other, of course. The indication and calculation of the degree of correction is the key factor in osteotomy. You need a complete analysis of the underlying pathology, of course, the complete diagnostics. MRI and long leg standing x-rays are mandatory, sometimes a CT scan in terms of rotational errors. And of course, the surgeon must be capable of addressing all the pathologies just described.
Muchísimas gracias. Thank you so much. A continuación, el doctor Robert Marks. Dan, quiero hacer una presentación especial a Dan, quien fue
Very special presentation to Dan, who was the person that received this when I had the opportunity of being the godfather of AUSSM, and therefore this team that's led along with Bob Skeen. I formally recommend for you to get in touch with him and that you can visit a center of excellence.
So Paulo approached me about giving a talk that was more philosophical than academic. And so you won't learn anything about orthopedics in this talk, but the goal of this talk is to try to convince all of you, or at least some of you, to take an orthopedic sabbatical. So I practiced at the University of New Mexico in Albuquerque, New Mexico. So my only disclosure for this talk is that I took a one-year sabbatical in Lyon, France back in 2015. I was with Philippe Nere's group there, and it was magnificent. So what is a sabbatical? The best definition that I've found for a sabbatical is an opportunity for self-improvement through a leave of absence with full or partial compensation. So I think the key parts of this is you improve yourself by taking a sabbatical. It requires a leave of absence from your normal job, and you get some compensation for taking the sabbatical. So where does the sabbatical come from? Well, it actually has biblical origins. So back in Leviticus, God said to Moses that you should plant the crops and harvest the vines for 6 years, but on the 7th year, the fields also need a period of rest. And I think this also applies to us as orthopedic surgeons. So in America, the first system of sabbatical leave was established at Harvard University in Boston back in 1980. It is now very common in America throughout higher education, and approximately 5% of university faculty in America take a sabbatical each year. However, I would argue that in the medical schools in our universities, very few faculty actually take advantage of the opportunity to do a sabbatical, and I think to the detriment of medical education and to the professors of medicine. And if you look, sabbaticals are not just taken by university faculty. Many businesses have recognized the benefits of a sabbatical, and they're taken, sabbatical opportunities exist for all of these major companies and many, many others that I did not have listed here. And even some sports figures have taken sabbaticals. This well-known basketball player took a sabbatical to play baseball for several years in the middle of his career, and I would argue it made him a better basketball player and may have prolonged his career. So what is the purpose of the sabbatical? Well, this actually comes from the faculty handbook at the University of New Mexico, and it says that the faculty who qualify apply for a sabbatical to encourage professional growth and increase competence by subsidizing significant research, creative work, or some other program of study that is judged to be of equivalent value. So why take a sabbatical? What are the advantages of a sabbatical? Well, this comes from a educational journal, but the advantages for the faculty member taking the sabbatical is rejuvenation and renewal, a time for reflection, a fresh perspective on your field of study. You're building new professional relationships. You become or stay current in the discipline, and it enhances your teaching. And I'll go through each of these in a little more specifics. So rejuvenation and renewal. During my 1 year in Lyon, my wife and I had the opportunity to experience the food, the drink, and the culture of France and Europe. And it really, I think, rejuvenated me in my career and really helped prevent burnout, which is getting very common amongst American orthopedic surgeons and physicians. There's also a time for reflection, and whether you're in a gondola over the French Alps or on the southwest Atlantic coast of France, there's great time to think about not only things in your personal life, but also things in your professional life. It also gave me a fresh perspective on how I approach things, and I kind of learned some of the French and European ways to approach things. And these are techniques that I brought back with me to New Mexico. The first is a case of a combined high tibial osteotomy with a total knee arthroplasty in a patient that had an extra-articular tibial deformity in addition to their severe arthritis. And I had seen Philippe Neret perform this several times during my year there, and it really piqued my interest. And when I had a patient that presented with that problem, I knew how to address it. The burden osteotomy is a great opportunity to correct and balance a knee with severe valgus deformity. I learned how to do a trochleoplasty from the people that pioneered trochleoplasties, as well as how to perform a deflection osteotomy to decrease tibial slope, as Tobias just talked about. I think most importantly, I built relationships. The Sebastian Lustig on the left and Philippe Neret on the right are both phenomenal orthopedic surgeons, but more importantly, I now consider them great friends. I became current in the discipline. I was able to participate in research projects during my year in Lyon. I was able to scrub in on surgeries to learn and be supervised on some of these newer techniques. And I got to participate in multiple courses during my year there in Europe, not only in France, but also in Spain. There's also a value to the institution with the faculty member taking a sabbatical. It enhances the reputation of the university, and you bring back new knowledge to your university. So again, I think it helped increase my productivity when I got back. I was recharged. I was ready to hit the ground running. I was ready to try some new and difficult cases. It helped strengthen, I think, our program. I brought back techniques that I taught the residents and some of our other faculty members. It improved morale for me. It also enhanced my loyalty to the institution for supporting me during my sabbatical year. And I think it enhanced the academic reputation of the University of New Mexico in Europe. And it has subsequently paid dividends. We've had several of our residents that have spent a few months in Lyon with the group there. And I got to introduce my chairman, Bob Skank, to Philippe Neret, and they are your two co-presidents of this meeting. So there are some arguments against a sabbatical. Some people talk about the financial cost of a sabbatical because you're not getting paid your normal salary during that year. But I think with some planning ahead of time, you can really minimize the financial cost. And I would say that the experience that I had was priceless. Some people told me I would lose my surgical skills. I would argue that I learned new surgical skills during the year that I spent doing the sabbatical. Other people told me I would lose patients and my practice would suffer by taking a sabbatical. But I found when I came back, patients were excited to see that I had learned new techniques from France. And it actually, I think, increased my reputation in the community. And then finally, there's a disruption of your family. But I would argue that my friends and family came to visit us in France. This is a picture of my son and I having a glass of wine at a Bouchon in Lyon. And they all had an amazing time when they came to visit us. So in the Journal of Medical Education, they evaluated what did faculty members think of sabbaticals, and 80% of it rated greater than or equal to 8 out of 10. And 3/4 of them said it resulted in substantial academic achievement. To me, the keys to a successful sabbatical are planning. You have to do it with the right person, and Philippe Neret could not have been a better host for me, as well as a great person to discuss cases with. You want to do it at the right time, you want to do it in the right location, and you need to plan ahead financially. And I would encourage, if you do think about taking a sabbatical, to step out of your comfort zone. And again, going to Lyon was a different culture, a different language, and a different approach to orthopedics that all broadened my horizons. So is a sabbatical worthwhile? In my mind, absolutely yes. And again, in this article, they said that the benefits both to the individual and the institution should allow us to keep having a sabbatical. And then the international connections I met in Europe, I've also had the opportunity here at the University of New Mexico with Bob Skank and myself to host the traveling fellows, every group that has come from SLARD from 2006 to 2018. I really only have one regret taking my sabbatical year, and that was that I missed the 2015 traveling fellows from SLARD, led by David Figueroa. So I want to say merci beaucoup to Philippe Neret, Sebastian Lustig, and Elvire Servien for being great hosts for me in Lyon. I want to thank Bob Skank and UNM Sports Medicine for supporting me during my sabbatical year. And then I want to thank all my SLARD friends, and particularly Moscow and Paulo, for organizing a great conference and inviting us to come speak. Thank you.
Asian Pacific, la sociedad y su sociedad ha sido extremadamente generosa con SLARD y ha enviado, por cuestiones de pandemia, todas sus conferencias pregrabadas, pero han tenido la generosidad, independiente del horario, del uso horario, que entre algunas partes puede ser de 12 hasta 14 horas, y se han conectado en directo. Tenemos la conferencia pregrabada del doctor David Lee sobre Single Stage Cartilage Repair.
Good afternoon, everyone. I'm Dr. Dave Lee from Singapore. I'd like to thank SLARD as well as UPCAS for inviting me to give this lecture on cartilage repair. My talk today is on single-stage cartilage repair using BMAC and scaffold. So this was my last trip overseas. I've not traveled since. This was in March of 2020, where I had gone to the SLARD meeting in Santiago. Then prior to that, the Magellan meeting in Bariloche. So looking forward to travel again. So we all know the problems with cartilage treatment, the challenges. Well, we know the poor durability with microfracture, with failures on 5 years. We also know that most cartilage transplant procedures require 2-stage surgeries. High costs are involved, over $40,000 with treatment. And because of this high cost, there have been issues with reimbursement from insurance. And of course, the problem with the need for open surgery in the second part of the cartilage resurfacing. Well, this, we know there's ACI that started in 2000, prior to 2000, and may see that with the results coming out in 2010, metric-induced cartilage transplant. Of course, with this, with all the problems with cartilage transplant, people started looking at doing autologous matrix-induced chondrogenesis, a one-stage solution, and we published this review article in 2010 looking at the results. And this was at a time where a lot of people were not keen on doing 2-stage cartilage surgery with cartilage transplant. This progressed on to combining AMIC with BMAC, and with the results published in 2012. And of course, this has moved on to the use of BMAC scaffold, and I'll elaborate this further with more results of these coming out in 2015. So why do we use BMAC? So BMAC has cells. These are mesenchymal stem cells, multipotent progenitor cells, as well as contains growth factors and cytokines. And these various growth factors and cytokines help to support cell growth and repair. So why use BMAC? So mesenchymal stem cells can differentiate into mesenchymal-derived tissue. Cultured mesenchymal stem cells in expansion have great costs. The use of bone marrow aspirate alone has a low percentage of MSCs. When you concentrate it, it actually increases by about 100 times the amount of growth factors. So that would be the effectiveness of using, let's say, BMAC versus PRP. So why use BMAC for its growth factors? Because they help to modulate inflammation and help to modulate and improve cartilage resorption and repair. So what is the use of BMAC currently in North America? In this article in Journal of AOS in January 2021, 560 AOSSN members were surveyed and about 27% responded. We said, so 165 responded. 2/3 used one biologic. The majority used PRP or NEOA. Some people use BMAC, 30%. So BMAC was surveyed to be the most commonly used biologic in this group of sports surgeons for focal cartilage lesions, as well as injections for focal cartilage lesions. So how is BMAC applied? As mentioned, it can be applied as an injection, or it can be applied or introduced directly in the subchondral bone. So these, in the case for osteoarthritis or bone marrow lesions, we are now talking about using it to be seated on a scaffold for repair of a cartilage lesion. And this provides an environment for cellular differentiation and to maintain cells in the lesion. So why do we use BMAC for cartilage repair? It's mainly for the cells. As Eric Cotter talked about, he suggests that BMAC would help to stimulate a more robust hyaline cartilage repair tissue. So the cells help, and so we use it for the cells as well as the growth factors, which help to protect and repair the subchondral bone. Well, this article by Connie True in JBJS 2018 showed that by leaving the subchondral bone intact, by not doing a microfracture, it helps to protect the subchondral bone and improve overall outcomes in cartilage repair. And this is based on an equine model where they compare doing microfractures versus not doing microfractures in the cartilage repair series. In the equine model, they found that there is less damage to subchondral bone. So this would be one reason not to maybe do a microfracture for the marrow stem cells and rather use the cells coming from the bone, from the BMAC as the cells for cartilage repair. So we talk a bit about scaffolds. On the left, you have a hyaluronic-based scaffold with an AMIC procedure. On the right, an injectable scaffold. So there are various types of scaffolds. There are injectable, there's a chitosan-based scaffold. There are also collagen-based scaffolds. So you can see that an injectable scaffold applied onto a medial femorocondyle lesion on the right side, applied on a vertical wall, remains stable even with range of motion. So there are various types of scaffolds, solid versus liquid or gel-like. So what is the evidence of using BMAC with scaffold? Well, these two studies in 2013 as well as 2019 AGSM by Gobi have shown that there's 80% hyaline-like cartilage seen on repeat MRIs with good post-op outcomes. We now do a single-stage cartilage repair using BMAC and scaffold for all chondral lesions more than 2 cm squared. The scaffold helps to promote differentiation of the stem cells. We use either a collagen scaffold, Cartifil, or a chitosan scaffold with scar gel that allows the scaffold as well as the BMAC loaded onto it to be applied on difficult to reach areas, such as in the inverted lesions of the cartilage or in vertical lesions in the medial femorocondyle. The BMAC is usually harvested from the iliac crest, and this provides a good source of mesenchymal stem cells. Adding BMAC also, in this case, avoids a microfracture that you will sometimes do in an AMIC procedure, and this protects the subchondral bone, as we have talked about. It has been shown by Snow et al. That BMAC with scaffold does not affect the properties of the BMAC. Adding the BMAC to it does not affect the concentration and the properties of the BMAC. So we go through a case here. This is a 41-year-old police officer in the elite police unit. He complains of left knee pain for 2 years with recurrent infusions, with neutral alignment, with no ligamentous laxity and no patellar maltracking. So we can see a thickness patellar lesion as well as almost 2 cm chondral lesion on the side of the trochlea. This can be seen in the axial as well as the sagittal cuts. We run through 2 videos. The videos on the right show the harvesting of the BMAC using the harvest system. This is done, can be done percutaneously. The central video shows the preparation of the trochlear lesion. So this is a significant, almost 2 by 1 cm chondral lesion in the trochlea, full thickness. This is prepared and taken down. And this is a 1 cm by 1.5 cm lesion on the side of the patella. So we prepared using a mixture of cuvettes and shavers to get a smooth margin. We remove all flaps. After preparing, we do not do a microfracture. We convert to a dry arthroscopy. We dry the lesion. We do not do a microfracture because we want to protect the subchondral bone. Upon drying, we now apply the BMAC and the injectable scaffold. This is a collagen scaffold with BMAC that's harvested from the islet crest loaded in to cover the trochlear defect. This is a fairly irregular shaped defect in the trochlea, and the lesion is covered. We proceed to apply the mixture onto the side of the patella. This is an inverted lesion. And we apply the gel-like scaffold onto the patella as well as the trochlea. The knee is taken through a range of motion after we check stability. And then we turn on the arthroscope fluid to check that this gel-like mixture remains in both the patella as well as the trochlear defect as we take it through a range of motion again. So you can see that the scaffold remains even with on wet arthroscopy and remains stable with range of motion. So this is how we repair a kissing lesion on the trochlea and the patella using a BMAC and scaffold mixture. These are a series of pre and post-op MRIs looking at the field. You can see that after 18 months, the patella side is filled, and on the trochlea side, on the right, the trochlea MRI shows fill at 18 months as well. These are pre and post-op sagittal cuts, which again show the same thing with preservation of the bone surfaces. Well, I've also done MRIs to compare if we had just done a scaffold BMAC on one side versus microfracture, and you can see that the fill with the scaffold BMAC patients actually have better fill and better coverage as compared to those with microfracture. So again, what is the evidence? The most recent evidence in arthroscopy 2020, Kim MS et al. Multi-center RCT BMAC with injectable collagen scaffold is better than microfracture alone. And this is based on improved MOCAT scores in defect repair and filling, better improvement in VAS and Cook scores. Cotter, in his summary in Cartilage 2018, has shown various authors, Gobi and White, as well as Kirch, who have shown that the use of a scaffold BMAC has good improvement at between 1 year to 4 years follow-up. Our own experience with 21 patients with lesions treated in various parts of the knee show an average improvement in Lishom of 26 and a Kuss average improvement of 23 at a follow-up of over about 43 months. So in summary, BMAC and scaffold, BMAC has a role in osteoarthritis and cartilage repair. It supplies mesenchymal stem cells, and growth factors, is increasingly used by orthopedic sports surgeons. BMAC and scaffold has good evidence as a one-stage cartilage repair with better outcomes and MRIs. Thank you very much. These are my friends from Latin America, as we have hosted them, I think, for 3 times in Singapore. And so thank you once again. Thank you, SLARD. Thank you, Upcast. Hope to see everyone again soon. Stay safe, stay healthy. Thank you.
Los invitamos a pasar al salón número 3, donde vamos a tener una...
Go to room number 3. We're going to have a small opening ceremony with our president, Mr. Manuel Mosquera. Thank you so much.